Welcome. Welcome, everyone. Welcome to our monthly webinar for the HSPN. And today's topic is the generation of integration, lessons learned in Ontario. We've got a great lineup today. Please let us know who you are by introducing yourself in the chat. And in the chat, you can say your name and the OHT or other organization that you are associated with. Ingrid from KW4, Ben Robert from Ottawa, Kimberly Van Wyck from Huron, Perth, Marjorie from East Toronto. This is when they really start coming fast. Teresa Greer, Monique, welcome. Welcome, Katie Dainty, North York and U of T. It's wonderful to see you all. Type into the chat, see everybody from Eastern New York, from Sarnia, Karen Davies from Elgin, Julio, Annalisa from Brampton, Mary, Chloe from East York. Welcome, everyone. We have over 160 people today so far, and people are still signing in. It's going to be a really great discussion, and we're really looking forward to our conversation today. Thanks very much for joining. My pleasure to be bringing you today. So we're going to start off today with a quick little poll and find out if you have joined us for the first time. Have you joined us for a webinar before, or is this your first time? Please click yes or no. You've joined us for a webinar previously. Welcome to everybody still joining. And type your name and where you're from in the chat, and please answer this poll about whether you've joined us for an HSPN webinar previously or whether this is your first event. Okay, we're going to end this one off. See if you can see the results. It's half and half. How about that? Half and half. So we have half new people and half old. So it's about 80 people joining us for the first time and 80 people returning. Welcome to all the new people, and I really hope that we can have a great event with you all today. I wish today I'm coming to you from the University of Toronto, and we wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And we acknowledge that Canada and your homes are home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of these many traditional and treaty territories. I want just everybody to be aware we're going to see a few people today from this team. But also that we are backed by a really robust and rich team of individuals that are helping prepare all of this work as we head forward into the evaluation. And today I'm going to host for a little bit, and but mostly we're going to hear from a really, really great suite of very experienced people. Dr. Guy Mboldania and Dr. Agnes are going to come and help talk with us a little bit about some of our academic work in the past. And then the people with great experience, Jennifer Bauman, Mark Pham, and Carolyn Goss, are really going to give us some stories from the front lines of what it really felt like to be implementing some of our models of integrated care that we had in the past. So this is going to be our talk today. And we're going to hear both, if you can think about who these people are. We're going to hear a lot about health links and integrated funding models and what we can learn from these past experiences, lesson learned from health links We'll have an academic and a practice perspective on this and lessons learned from the integrated funding models. And then we're going to have discussion at the end and questions and answers, but we're also going to have chat and discussion all the way along. I think there are going to be some really important thoughts brought up along the way, and I'm really looking forward to the opportunity to both hear from these people, but also to hear from you. So welcome. We do 2 other quick little polls, and that is just to get a little bit of a level set. The first one of these is to find out where you're coming from today and which category best describes your role as it relates to Ontario Health Team implementations, patient caregiver, health administrative leader, a provider, and we're interested if whether you're currently in an approved OHT or otherwise, ministry or another group supporting the OHTs and everyone else, just because I didn't want to create 5 more categories. So let's see where people are all from today and share our results. And we see there's a lot of administration, a few patients and caregivers, and then healthcare providers, ministry agencies, and a lot of people like me, the hangers-on in this interesting world. Thanks very much for joining us from everywhere across the province and all of the OHTs. We have one last poll, and that's to get a sense as we just talk about health links and integrated funding models today. I would expect that many people are very familiar with these, but I'm just going to ask because some people may not know about these. So please choose one of these 5 options and let us know whether you were very involved in both of these initiatives, one or the other. You kind of heard about them. What's your choice? And let's see where people are from. Quite a few people actually know about them, but haven't been very involved previously. So that's you're going to learn today a little bit about some of our key learnings from these. So I think that's going to be a bit of knowledge. And for those that were very involved, you may have other thoughts to share through today. And so I appreciate you're all joining us and a chance to learn. And okay, I have the great pleasure today to introduce our first speaker, Agnes Grudnevitz from the University of Ottawa. And she's going to talk about some work that was done when Agnes was still working with the Health System Performance Research Network at the time at the University of Toronto, and we try to set up our work for Health Links. And so Agnes, I welcome you to join and start leading us through this little bit of knowledge that you've had.
Great. Thank you, Walter, for the welcome. It's really lovely to be back. As Walter mentioned, I did my postdoc with the network, and I must say the opportunities afforded to me in doing research with HealthLinks, I think, had a major role in building my career. So I'm forever grateful and very excited to be back to share some of the findings from that work. Next slide, please. So Walter asked me to talk about some of the lessons that we put out in a publication in Social Science and Medicine back in 2018. And these are still really relevant and personally, I think, interesting. I'm a bit biased since I wrote the paper, but I also wanted to acknowledge the co-authors. We had Tim Tenbensel, who we worked with in New Zealand, as well as Jenna Evans, Carolyn Stilgray, Ross Baker, and Walter, of course. Next slide, please. So what we did is a study, of course, it's a research study, and I'm here with the academic perspective. Hopefully I don't bore you too much with that, but I think we did some interesting stuff. So back between 2014 in August and February 2015, we conducted semi-structured interviews with 55 clinicians and administrators. And I'm willing to bet some of you on this call actually participated in an interview that was conducted either by myself or Jenna Evans. Back then, we had local health integration networks, and we interviewed 26 employees at these LHINs that were involved in HealthLinks implementation. And we covered 38 of the 56 approved health links at that time. So we had a lot of representation from primary care, from hospitals, and from community-based organizations. We took the interview transcripts and coded them with concepts from complexity literature. That's what we were interested in, and I'll dive into that a little bit. And this study was part of a broader project that we were working on with Walter, where we examined organizational factors that are needed to support successful implementation of integrated care. So really, we were looking at the implementation of the health links across the province at that time. We asked our participants to speak to their approach for implementation and the role of the LIN within that. What was working well and why, what challenges they experienced, and then also what similarities and differences they perceived between their health link and other health links. Next slide, please. So I mentioned we took this complexity lens. We looked at the health links policy as a complexity compatible policy, and I want to take a moment to explain why. So often we look at integrated care from a linear perspective, where we see that integrated structures lead to integrated processes that then produce integrated care. I see a comment as to whether it's possible to get this article. So yes, I think Walter can probably disseminate that as well. And now I will try not to look at the chat pop-up. So essentially, the linear view states that there's a cause and effect relationship, and that when you put in specific inputs, you can expect specific outputs. In reality, I'm sure all of you are thinking, yeah, no, that's not the case. We all know on this call that integration is messy. It's really unpredictable, and the fact that it's nonlinear makes it very difficult to plan. So on the right side, you see the complexity view, and this is more the reality where we have multiple connections. And we could see that when everybody introduced themselves, how connected we are across the province. The system cannot really be understood in its entirety because there's so many interacting variables. I'm not sure anyone on this call can really describe everything that's happening in Ontario right now. We can't know everything all at once. There's also opportunities to spontaneously self-organize without external forces. And there's continual adaptation. And within this kind of setting, any attempts to force or prescribe change can actually be counterproductive. Instead, we want approaches that are adaptive, that are going to be much more successful than efforts to kind of create this mechanistic or linear top-down approach. Next slide. So health links was deemed to be a complexity compatible policy by our research team for several reasons. The main being the low rules / no rules environment, and it being implemented, especially at the start, with very low rules. It was meant to stimulate grassroots solutions to local problems, so very much bottom-up attempts. And it encouraged new relationships between organizations across social and medical sectors. As well, we did a quick review of the documents, and a lot of the official documents aligned with complexity theory. They described the health links as voluntary self-organizing systems that used a flexible approach. So we felt that it wasn't a hard leap to make to call them complexity compatible. Next slide. So I'm going to today provide an overview of the three main themes we found in the data, and I'll take you through these very academic terms. And then we'll talk about the lessons learned at a systems level, the challenges that were faced, and the lessons we can take forward as we work with newer initiatives to integrate. So the three main themes in the data were sense making and interconnections, self-organization, and co-evolution and emergence. So on the next slide, I talk about sense making and interconnections. So sense making is how we work to understand new or confusing events. And we found that in HealthLinks, this was really facilitated by connections with other organizations, where just by getting to know others or working with other organizations, it stimulated collective sense-making as people came together to understand, interpret, and apply the HealthLinks initiative within their own context. Sense-making was also influenced by receptivity to a low rules approach. Just back one slide, sorry, Walter. And this receptivity to a low rules approach it came from past experience. So anybody that's already worked with ministry initiatives that didn't have a lot of guidance, and also personality. So some of us are more comfortable with uncertainty than others. Next slide. Self-organization is this process where people and organizations mutually adjust their behaviors to achieve order spontaneously. So it's any initiative, things that we do without necessarily being told to do it. And I think in healthcare, we do a lot of that as we try to improve how our health services meet patient needs. Some people took a structured approach where they got very far on paper, but not really in practice. And others jumped right in with an iterative approach. They started seeing patients and figured out the rest. And that was much more successful, actually. We also saw self-organization where there is pre-existing self-organization. And this quote from a LIN stakeholder really gets that across. That's where we're seeing the biggest impact of HealthLinks in environments that were ready for HealthLinks, who were practicing HealthLinks long before HealthLinks. Okay, next slide. So coevolution and emergence are the most theoretical, kind of removed from reality terms from the academic literature on complexity, and I struggle to wrap my head around them sometimes if I haven't had enough coffee. But I'm going to explain them here really briefly. Coevolution is the process where the system influences its environment and the environment influences the system simultaneously. And that's sort of why it's very difficult to describe a system at any point in time because of that adaptation. And emergence, put simply, is the creation of new properties of the system. So we didn't find a lot of this in our data. And instead, we found it in people's vision for HealthLinks, what they wanted it to look like. They were all really hoping to push from local to systems change. There was a desire for stronger governance, MOUs between partnering organizations, creation of HealthLinks structures that are less dependent on LINs. And they really wanted to have their initiative influence the ministry and HealthLinks across the province. But the barriers included poor or inconsistent communication and accountability between the ministry, the LINs, and the HealthLinks. And that hindered a lot of the learning from moving up through the system for that, to meet that system's view. Next slide, please. So systems level change didn't actually come up in our data, probably because of the time point at which we collected data, but it's arguable whether it did after or not. We did conduct more interviews with Jennifer Gutberg and a few other members of the team for a separate study, conversation for another day. But essentially, there was a need for a clear vision from the ministry, which our participants felt was lacking in order to create systems change. There was a need to move from coming together. There was a lot of focus on always coming together, getting to know each other. How do we do this? Figuring it out, to actual sustainable improvements in care coordination in the province. And more of a systems focus was needed in order to move resources across organizations to where they were needed most. Next slide, please. Challenges in getting to this place included difficulties, as I mentioned, from sense-making to actual practice change, not even systems change, but actual change in practices. A lot of the bigger organizations got a little nervous and didn't actually proceed with the changes they promised. There was a lot of arguments around standardization versus flexibility. So people felt that in a low rules or no rules environment, and this is a quote from our data, you spend an awful lot of time herding cats and creating chaos in the system. And then people that actually were doing quite well with their innovation, for them, one participant said, it's almost too late. You know, people have done the work and they're on their way, and now you want them to conform to something else. It's very difficult. And so that led to fragmented learning and fragmented change, where the ministry invested a lot of time into small, disparate initiatives without facilitating the flow of learning into large-scale, coherent solutions to system-level problems. And that was our perception based on the data that we collected. Next slide, please. So what are the lessons learned? What can we actually take and move forward? Well, first, we did find that complexity-compatible policy stimulated experimentation and learning. So creating low rules environments does actually create some really cool stuff. But that resulted in a piecemeal and patchy approach. And we found that not everybody had a complexity sympathetic mindset. And in places where they didn't, it wasn't great. We also found a need to have enabling leadership. So these are leaders that actually disseminate innovation from the bottom up into formal systems. And these people need special skills because what they're doing is coordinating self-organizing systems in the real world that are constantly adapting and changing and fluid into learnings that move quickly and efficiently into our existing top-down hierarchy and systems. And then also, and this is, it requires a dance between flexibility and consistency, and that's where that leader really takes a key role. And there was a recommendation from participants for core components that they felt were lacking, with more of a focus on the adaptable periphery. And this is very much supported in the literature on implementation science. With more flexibility comes the risk of lower quality of care, and that's a big problem. Lower quality is a big problem in healthcare, and that patchy approach could create differences in quality across the province. And definitely not least is the idea of feedback cycles to move learnings up the system from the ground up quickly so that we don't lose momentum. So last slide. On the next slide is, oh, sorry, there we go. So we found that some health links were very successful, but not all settings were. Indeed, innovation failed to flow upward to higher levels in order to scale the initiative. And that was what we were finding in 2015. I'm really only speaking to that data, and we can have a discussion after with actual experts on the ground about what if that continued to be the case. Now, policy for integrated healthcare is more than simply letting 1,000 flowers bloom. A low rules environment is necessary, but it is not sufficient to achieve better integrated care. And some of this did occur. Some of these scalings and learnings did occur. As you know, many of you probably know, in 2015, the ministry responded to calls for standardization. They issued the guide to the Advanced Health Links model, which aimed to standardize and embed many of the innovative practices across core areas. But as that quote I shared a few slides ago showed, sometimes it was too late, and it led to a lot of frustration for people. And that signaled that we were, the flow of information up to policymakers was really too lengthy. It took too long, and that came across with participant frustration and concerns about decreasing momentum. So what are the recommendations from our study? First, do foster and leverage contexts that have capacity, whether or not that's resources or a mindset capacity to deal with uncertainty and ambiguity. Develop feedback mechanisms for bottom-up learning, and I want to say efficient, fast feedback mechanisms that are structured. And then also, while allowing for local variety, there needs to be regular nudges toward consistency. And that needs to be done with enabling leaders that are really able to straddle both worlds. And that's it for me. Thank you.
Thank you so much, Agnes. Really appreciate that. Insights from 5 years ago or so when we were undertaking these interviews across them. I encouraged people to use the chat to indicate some of your reflections. And we're going to come back to some Q&A at the end, but please do share your reflections from your experience. Many of you were involved in Health Links and are still involved in the outgrowth of Health Links. over time. So we're just going to move now to a little bit of fireside chat. I'm going to try to start my video, and hopefully we can also have Jennifer Bauman and Mark Pham be able to join us here. Great, I see Mark and I see Jennifer, and we're coming to you from a little partially falsified same room environment in some ways. We can see the real Mark. I'm going to ask you both. I mean, Mark is now vice president. People at Michael Guerin has moved on from the Health Link that he was involved in with Jennifer. Originally, they were both at North York. Jennifer is now a vice president at Unity Health. But I thought, we learned a lot, and I will say that I got to know Mark and Jennifer in the era of health links because they were some of the first people to be challenging their own successes and whether they were being successful. And I thought that courage was really inspiring because on some of the more external views of whether health links were making a difference in healthcare utilization, we actually found it wasn't the case. And so we wanted to and they were interested in exploring a little bit deeper into this. So I'm just going to start, maybe Mark and Jennifer each. You'll go maybe Mark first and then Jennifer. If you could start sort of with your role and experience with the North York Health Link and what your awareness was of other health links, and that could be specific or general. So Mark.
Sure, yeah, I can start. So we were early adopter health links, I think in the round of first 26, and I guess awareness of the others, through the good work of the ministry at the time, there was a good community of practice started in the early days, probably not as advanced as what the RISE platform is today for OHTs, but certainly some early dialogue that kind of helped us learn from others as we proverbially built the plane as we flew it. I think is kind of the what we attempted to do. And I think a lot of good lessons learned from the early health links days that we're certainly bringing into the OHT discussion as well.
And Jennifer.
Yeah, so Mark and I were both involved right from the submission through the early years of the Health Link. And I think it's important to note, based a lot on what Agnes said, that North York was a little bit ahead of the game in that we started with a very strong Department of Family Medicine, a large family health team, and some pretty good connections with the community. And so I think that gave us a little bit of a head start in terms of getting our Health Link up and running and moving it forward.
Yeah, thanks. And I think, dive down now maybe a little bit to some of the lessons learned from each of your perspectives. And I'm going to be interested to see if there are any differences in what you learned, given that you were working with the same Health Link. But just so why don't we say maybe top three, and we'll explore from there. So if I would say maybe either one or three things. So if you can want to focus on one, that's fine too. That went well with the Health Link that you'd want to replicate. Let's start there. Jennifer, why don't I start with you?
So I think for me, the biggest learning was the importance of relationships. And I think this is something Mark and I have talked about, but we had a pretty cohesive steering group. We had strong relationships. We had common goals, and those were all key things to get us going. And I'll maybe just add one more and then turn it over to Mark. But for me, one of the greatest learnings was this was really a great opportunity to reach out to community agencies and to increase the opportunities to work together. It was just so common to sit around the table as a group and say, well, I didn't know you did that. And I thought that was a gap in the system. And here I find out that you're providing that service. And it just, I think, highlighted how much was going on and how difficult it is for any provider or any consumer, any patient, to have a good sense of what's going on in the healthcare system and how to get what they need.
Yeah, so maybe building on that, Walter, and I completely agree with Jennifer, it is all ultimately about relationships as the top one, but maybe related to that is this idea of agility and grace. So agility, being able to flex quickly, and we just, as Jennifer just shared, every day we would learn a new thing about what each other was doing. So how do we be really flexible in terms of how we implement what the intervention was for health links around this idea of coordinated care but grace also with each other to know that we're gonna stumble a lot, and that it's okay to stumble a lot and fail a lot and learn from that, and then kind of implement quick change. But to do that in the same spirit of what we were attempting, which is, ultimately building a system together.
That's thanks both. I mean, I think the relationships being really important, and in finding new ways to bring together people to meet patients' needs. I think that's really kind of what I heard there, Jennifer and Mark. Around grace, I do talk about how it's okay to fail, as long as we fail forwards. I will now think about failing forwards gracefully. But everything maybe we don't want to replicate entirely. We struggled a lot with health links. I think, Agnes pointed out some of the struggles in bringing, some of the best learnings to light for spread. I think there were also some challenges in really just getting people enrolled and tracked and sharing information. But so if I were to ask you one or three things that you'd want to change and do differently for OHTs, as compared to your health links experience, what would you say to that? And Jennifer, we'll start with you again.
So I think one of the things that has struck me is that maybe the system wasn't ready for health links. We kept trying to figure out how to solve problems at a local level that probably should have rested more at a regional or provincial level. So addressing the enablers, and I think we're in a better place, but I don't think we're in the perfect place quite yet. But things like IT connectivity, funding, for example, have we really got the right model for funding of primary care that's going to move us forward to a population management approach? And as well as information systems that support performance management, particularly across sectors. So looking not only at what's happening in any one of our sectors, but across sectors to see how it's affecting population management as well.
Thanks.
Yeah, I would agree. I mean, Walter, I would say those top three are the same for me. The answer is also kind of why those top three. So the performance management and that idea of investing in evaluation early helps us to know when to stop. Because HealthLinks was a great example where there were some really compelling individual case stories where HealthLinks made a significant difference to patient lives, but it may not have had the same systematic impact we hoped from the original intervention. So, that investment in evaluation to know what of the OHT experiment is working and what isn't. Even if I think about our early days for OHT investment, it's also investing not only in kind of performance, digital, and some of the relationship work, but it's also investing in the leadership capacity to really do this. We're talking ultimately changing a whole system. So how do you invest in the people and the time to help drive that? Even if you don't need more frontline clinical service, how do you really invest in the people and leadership effort to make the change happen?
Yeah, let me, thanks for that both. Let me pick up on that, Mark, a little bit, because I think that when you talk about leadership, I think about some of the adaptive challenges that leaders are going to have with Ontario Health Links, right? And by adaptive, I mean like leadership vision, teamwork, and supporting their local teams, and having that right balance between vision and direction, and enabling local leadership. So if you think about and some of the adaptive challenges in implementing Health Links that we'd want to fix. Or continue to work on, and maybe, I don't know if you have ideas on how we can fix or work on those around this. Yeah, so some adaptive leadership might be one, but you might pick a different one.
I can start, Jennifer, and you can jump in. I think some of the work, Walter, that you and the Change Foundation and others have been doing specifically around integrated care, and what does that mean from a leadership perspective and a competency and how we support each other, I think is some. OHTs will have an important challenge ahead in terms of governance. And it does come a little bit back to the funding question Jennifer raised around, are we funded and structured the right way? But even is our governance set up the right way? Because it's not only about, CEOs and VPs and managers, et cetera, kind of adapting, but it's also our governing bodies and how we enable boards to really shift and flex into what an OHT environment will create and what that means for their duty. And then I also think it's just about building focused capacity. It's the idea of investing, making small investments up front to lead to a much bigger spread and change is probably what we need. And Jennifer and I were lucky to have a great team at North York that really helped drive this work in the health thing. what we'll need in similar models for the OHTs.
Yeah, and just to add what Mark says, I think that we always have to remember too that it comes back to the patient, family, and caregiver. And the consistent message that we always get is that navigating the system to get to the right services is complex and frustrating, even for those who work in the system every day. And so when you come to that leadership and teamwork idea in the adaptive sense, the teams have to function at so many different levels. So from an Ontario Health Team perspective, a lot of the time we're focusing at that system or regional management team, where often it's people like us who are on the calls, who are administrators, but there's also the team that's around the patient. And so how do we as the enablers also facilitate that team around the patient? One of the things I think we found with HealthLinks was a core part of that was care coordination. In order to have care coordination, you had to have groups that were willing to work together, and including the primary care physician, the specialists, some of the community agencies, the home care people. And so that became a team as well. So I think teamwork isn't just at the leadership of the Ontario Health Teams, but it's also enabling the teams that are around the patients that are providing direct care that we have to think about as well.
Yeah, thanks for that. I could sit and talk about lessons learned here for much of the next period of time, and maybe even all day. But we want to hear from some other initiatives too. But maybe I'll just give you a chance, Mark, Jennifer. Do you have any parting thought on your vision for OHTs? Yeah, we'll just leave it at that.
Go ahead, Mark.
You want to go first, Jen?
No,
right,
you
I'll
go.
go first. OHTs are an exciting time. I genuinely believe there's a lot of opportunity here to really push forward on the vision around population health. And that is, both on an adaptive leadership challenge, a significant shift from probably how many are trained to really think about population health. So I think that's where there's a lot of opportunity, but it's the long game. And so the short game, I think, is continuing to build just on the success, coming back to relationships with the partnerships that are built early in the HealthLinks days, many of which migrated into the integrated funding model days, which I know we're going to come up to shortly. And then have, again, built the runway to get to OHTs. So I think it is reflecting that, OHTs represent a great population health opportunity, but it builds on the partnerships that, regardless of how policy may change, is those partnerships that actually drive the integration between all of our sectors across health and social service.
Yeah.
Unity Health, because of its makeup with St. Joe's and St. Mike's and Providence, is involved in a number of Ontario Health Teams, so 4 in total, and each of them is a little different. And so I think it's that tension that Agnes was talking about around allowing that local growth, allowing to address local complexities with some system consistency as well, and so how we actually, I think, balance that difference, and how do we bring individual communities and regions along, and at the same time develop a system overall, I think is the key challenge for Ontario HealthLinks. And I think success is a gradual thing where we, as Mark says, build on successes. Let's get some things in place that we can build on, demonstrate success, go from there, and move forward in that way. And I think it is the fact that this has got to keep going, and there's not a cutoff point. Like after 5 years, we don't declare OHTs either worked or they didn't work.
Yeah, I think that's a really, really wise thing. And I think, we need to really think about what we mean by OHTs working in the short, medium, and long run. And keep our view. I think Mark had a very good point on that, on what the long game is, while also incrementally stepping forward, even as we fall forward gracefully. Thank you so much to Agnes, Mark, and Jennifer, and they will be around so we can be keeping an eye on the chat and raising other questions. I see there is some chat coming along here, and I won't directly address it. Shannon from our team and Ruth are also responding in there, so thanks to them. Thank you so much to both. I really am pleased now to have the opportunity to move along and move into our next example, which is the integrated funding models. And I think some of you may have been familiar or aware of the integrated funding model, which is a pilot program of a bundled care model of various shapes and sizes in its origin, and then moving outwards into what is now being launched as bundled care across the province, particularly for hip and knee, but there are more to come. And this was a different form of integration, but more recent, so we've placed it second. And again, here we're going to hear about some of our insights from the evaluation and research that we did with integrated funding models, and then also some perspectives from the field with Carolyn Goss to follow. And I think, part of our doing this is it gives you a little bit of a flavor of how we think about evaluation as well, and how we're thinking about evaluation with Ontario Health teams. So with that, I'll leave it off to Gaia, and hopefully Gaia is able to come off mute and join us on video as well.
Hi, Walter. Thank you. I hope everyone can see and hear me. So good afternoon, everyone. It's really good to have you here with us. Thank you for sharing your afternoon with us. So let me actually get right to it. Next slide, please, Walter. Okay. So as many of you know, back in 2015, the ministry chose 6 programs to implement IFM, so integrated funding models, also referred to as bundled care by many people. So each of these IFMs had both hospital and community partners, and they could have anything from 2 to as many as 15 partners. So 3 programs chose to focus on episodic or surgical episodes of care, so cardiac surgery, stroke, UTI, and cellulitis, and 3 focused on chronic conditions, so COPD and CHF, right? So chronic obstructive pulmonary disease and congestive heart failure. So all 6 programs also essentially established integrated care pathways. All but one had care coordinator positions. They all offered 24/7 telehealth, and they all tried their best to provide shared digital access as much as possible across sectors to patient health records. So the aim, or rather the hope here, was that programs would develop efficient integrated care pathways and that they would essentially come together to improve outcomes relative to the cost of care. Next slide. Okay. So for the qualitative component of this work, because this was, of course, a rather large multi-method study, but specifically for the qualitative bit of this, our objective was to understand how integration was generated. So not just integration as an outcome, but very much integration is also a process, as an experience. And we did this by studying the interplay between contexts and mechanisms. So how did existing contexts, be it in existing geographies or cultures of physician engagement, become mechanisms that made other things possible? So for instance, things like trust building, that in turn made yet other things possible, right? So became the contexts for other things. And I don't wish to suggest that it was linear in any shape or form, much like, Agnes didn't, although in some cases it might well be, it depends on context again. But it's much more about the interplay between these structures, which either enable or frustrate other structures. So back in 2016, we conducted 48 interviews with leaders, managers, physicians, integrated care coordinators, across the hospital community spectrum of participating organizations. We also did some interviews with folks from LINS and the ministry. So again, we were essentially trying to understand how integration itself was generated, right? So how things come together, how systems and organizations are connected, but also how people and ideas, how practice comes together and sort of coalesce, right? So essentially integration as both connectivity and consensus. Next slide. So we found that integration could be generated by certain program structures, by leveraging existing partnerships, by fostering trust with partners, with new partners, but it could also be generated by developing thoughtful models, so models that were inclusive of as many sectors, of many participating organizations as possible, and models that sort of try to account for different risk scenarios. Including clinicians from the ground up also helped, as did attempting to sort of facilitate information sharing as much as possible across organizations. Next slide. Okay, so participants made decisions about how to structure the IFM, from what clinical population to focus on, to how many partners to include, right? And this was very much based on people's individual perceptions of what their own strengths were, what their gaps were, essentially what their need was. So I'm trying to showcase sort of a specific program for each of these themes, not to say that the other programs didn't reflect these very themes, they did, but I'm trying to sort of let you have a snapshot of what these programs actually look like. So this particular program ran into challenges because of differences in size, organizational culture, and resources. And it made it difficult for the larger organizations here to incorporate a smaller organization because it had difficult clinical practices, different IT systems into the fold. And unsurprisingly, the smaller organization too is quite frustrated. So this is from the perspective of the smaller organization here. So there's a new tool that the larger, better resource partners, are introducing for the OTs, but it's time over and above what they're doing already, their assessment. We are trying to pick it up. We're sort of asking ourselves, so is this tool that they're using for this charge, does it actually make sense that we change to this? Is this a good thing, rather than just blindly doing something? So it just indexes the struggle to integrate, given the lack of a level playing field. Next slide. So all 6 programs were leveraging or attempting to leverage existing partnerships in some form, but the depth of these relationships varied. So this is a program that was particularly successful at leveraging these partnerships. And it just so happened to be smaller, so just 3 organizations, 2 hospitals and a CCAC. And it so happened that they had already been through a back office integration. So their IT departments, their finance, decision support, and human resources departments had sort of already been brought together through this back office integration. They all shared a joint vice president. So even though they did still have separate budgets, there was a sort of same person who had oversight over things. And this is from the perspective of one of the leaders of one of those organizations. It was obvious when we went into this discussion that we would include all 3 partners, that this is kind of how we roll. Bumps have been overcome because we've been so comfortable saying, yeah, I'll take that on. I'll get that out of the way. I'll make that change over there. I'll absorb those costs, knowing that there was a trust factor, right? We were all in this together. So as a result of this program was able to easily move a hospital manager over to the CCAC to oversee the nurses over there. So this really helped to bring both sectors together, not just administratively, but also clinically. So obviously you can see here that the 3 CEOs didn't just respect each other, they actually genuinely liked each other. Okay, next slide. Okay, so this program focused on cardiac surgery, as you see here, and it was the smallest. It just featured 2 partners, so a hospital and a home care provider. And it was the first time that these 2 organizations had actually formally worked together. So in this case, the hospital had decided to bypass the CCAC and set up a direct contractual relationship with the home care provider. But despite the lack of this history of working together, they sort of shared a similar vision. They were both enthusiastic about working together. But as you can imagine, sharing patient care and funding data, that requires a whole different level of trust. And that trust, again, had to be cultivated from the ground up. And this is a hospital participant talking about this process. So initially, there seemed to be a lot of withholding from us on what their policies looked like. They didn't want them to go into the hands of other service providers in the community because of competition. So they had to trust us enough that we just want to see your policies to make sure that they coincide with what we are saying, so that there's not these big gaps in how we would provide dressing changes or IV therapies or whatever it is. But essentially, trust slowly developed over time. So what helped was the community clinical team visiting the hospital. They met with their colleagues there, they trained with them. And similarly, the folks at the hospital actually went to the community and folks described this as an eye-opener, just realizing that people actually work differently. There was a whole different set of infrastructure here, right, that they took for granted in the hospital that just didn't exist in the community. So they essentially inhabited each other's worlds, and that's what it took to develop this sort of trust. Okay, next slide. So this program was the largest of the 6. It had 15 partners, and because of its scale, there was a sort of extra need to pay attention to how to include organizations of different sizes and so on. And they did this by including and listening to the voices of different stakeholders, but also really thinking through different risk scenarios. So someone is talking about this process here. We said, what if volume is up 10%, but the referral rate is exactly the same? What do we do if 2 of the hospitals are referring at a much higher rate than previously? And then what if the volume is low? So this particular program went through a process mapping session, but this is something that many other programs did as well, as you see in the second quote here. The first thing we did is process mapping with a whole bunch of providers, and the process map would have wrapped around the wall. Then we parked that there, and we did the same thing with patients, and we did the same thing with what the best practices were. Then we put all 3 of these perspectives together, and that created this giant view of the patient's perspective, the provider's perspective, and the best practice. And we looked at where the gaps were and what we needed to do differently to rectify these gaps. Next slide. So programs typically engaged clinicians by including them in the model development process, addressing their concerns, and you know, if not having physicians lead this process, at least, you know, doing it very much in conversation with physicians, you know, trying to come up with an engagement strategy and a communication strategy that worked for them. So this particular program happened to already have a very strong history of physician engagement, but it was still trying to figure out how to incentivize even wider engagement. So it came up with carrots, like for instance, you know, it decided to enhance an existing CHF clinic, set up a new COPD clinic, and it decided it would employ respiratory therapists as clinical care coordinators. So physicians were very excited to think that we would have an RT following up COPD patient into the community. And so if the RT clinical care coordinator wanted to call the respirologist, well, they would already have that relationship versus, you know, a CCAC care coordinator where they don't have that relationship and don't have the confidence or the trust that they understand how to titrate oxygen or something. Now, getting physicians on board wasn't as easy for the other programs. If you know, and this wasn't surprising. So hospital-based specialists, for instance, had to be willing to provide care as a member of a team as opposed to a solo practitioner. And they had to sort of trust that whoever they were handing their patient to was capable of caring for them. And this is not very easy if you think of the community as this black hole, right, that your patients disappear into. So lots of trust building that had to be done, not just across sectors, across organizations, but also with physicians. Next slide. So little surprise perhaps, but sharing information across hospital and community and home care teams rather was a challenge for most programs. Now this program stood out in actually finding information sharing slightly easier than most. And this was because of a newly piloted electronic interface that they had. So this allowed everyone across the sectoral spectrum to sort of access the same interface and monitor patients in real time as soon as they were discharged. So this is a great example of how these 6 factors that we're talking about here really work together and build on each other, right? So yeah, so just because you have a great structural interface, as in this case, it doesn't mean that everything's going to be hunky-dory. So you first have to figure out, you know, are people going to use it? Are clinicians going to be okay with this? You have someone from the hospital talking about this here. So at the start of the project, the hospitalists, got the cool factor about the dashboard, but when the team said, when would you like to see this? They said, well, we actually don't. Call us when you need us, which kind of perpetuates the don't call me until there's a problem, and then I'll do it. But the team was very expert at slipping in the dashboard so the physician could see it before there was a crisis. Now, physicians are more aware of what happens in home, and so that is new information to them. Secondly, it's also helping them become more integrated and supportive of the in-home care team. So it's an example of infrastructure working not just because it existed, but because it sort of was successfully used as an agent for culture change, right, for integration. And really the implementation of any new initiative, if it is done meaningfully, is fundamentally a story about culture change, right? Or in some cases, if done not so successfully, perhaps the lack of it. So this could be adapting to a new technology, building trust, working differently as a physician, whatever it is. Okay, next slide. So in summary, we've been talking about how integration is generated through the successful confluence of people, practice, and things. So all 6 of these factors are certainly important, but you could argue that not all of them are absolutely necessary, right, for every single program. Certainly helpful, but perhaps not absolute prerequisites. So for instance, yes, obviously having existing relationships helped, but you could certainly build these relationships from the ground up if you shared a certain attitude, a certain vision, right? Having a certain IT infrastructure in place certainly helped, but it's going to be of little use if no one wants to use it because of a lack of engagement or a lack of trust. But in any case, these 6 programs certainly demonstrate the interplay between these factors that produces these different levels and intensities and forms of integration. Okay, so you can read more about this. This stuff has been published in a paper, and I'm sure we can share that with you if anyone's interested. And we actually have another paper coming out that talks about interviews we did 2 years after this, specifically with the COPD and CHF programs, really interesting issues with sustainability that these programs were struggling with. Okay, so I'll hand it back to Walter and Carolyn, who will hopefully take us through what some of this stuff looked like on the ground.
Thank you, Gaia, both for undertaking the work in the first place and then interpreting the information and now coming back today to share. And please, people who are involved in the chat, please do note in. And now I'm going to have a few words, a conversation a little bit with Carolyn Goss. And for those who are involved in IFM, know Carolyn extremely well, and others know her, I'm sure, somewhat for her leadership in the health system and supporting many ways. But I'll have to say, I was just amazed at how much support Carolyn, who had a full-time job, was able to give to all of the teams. And it came because of the work that Carolyn had done with Kevin Smith at St. Joe's in Hamilton over many years in building their integrated client care project. Carolyn is still at St. Joe's. She's vice president at St. Joseph's Healthcare and president of St. Joseph's Home Care. And I'm hoping that Carolyn is now able to be online with us.
You can see me, Walter?
Yes, there we are.
Great.
Lovely. Nice to see you there.
Mm-hmm.
I wanted to ask, you developed an effective model for integrated care through the ICC at St. Joe's in Hamilton. And then the ministry came out with this, integrated funding model pilot, and you were obviously, you knew that was coming and aware and helped some of the design aspects. And then you got very involved with the teams, like boots on the ground, frontline help, real task, explicit help. What were the things that you were bringing, like the 1 or 3 things from integrated client care that that were at the top of your mind as you were working with the other team? Yeah,
so I have to say it was honestly a great learning experience for me as well, Walter, as I was working with the 6 teams, and one of the 6 teams was actually an expansion of our work within H&HB. And we had a little bit of a dry run in some ways in terms of expanding the ICC model prior to the IFM. We started our work at St. Joe's in Hamilton in 2012, and then the following year we expanded to with our colleagues at St. Mary's. So that was a really good basis for us to understand how to help support the spread of a model without taking, frankly, a cookie cutter approach to this. And I think really understanding how to support a team through the implementation, recognizing context and different patient populations, et cetera. So when we reflected on the three things that we thought would be really helpful for the teams, the IFM teams to consider as they were implementing, the very first one was leadership. And I think we've heard this come through, through a number of the speakers already. Having that support from the leadership team is critical because in many ways you're sort of deconstructing the existing healthcare system. That may sound a little scary, and in some ways I think that's what we're looking to do to some extent in the OHTs and the health links models, but you're really reimagining how how you're bringing care together for patients. You're looking at it through a different lens on a longitudinal basis from acute to community, and it means disrupting really the existing system. So having that leadership support was, really critical for us. I mean, certainly Kevin Smith was, always had our back as we were implementing this work. And it's one that I think that we really imparted was important to have that leadership support, not just within the hospitals, but also within the LIN teams, our CCC colleagues, et cetera. That was really critical. The second, just as important, and we've heard this, I think, reflected again before, was to ensure that the frontline staff were engaged in this work, because the last thing that we wanted to do when we implemented early on was to have a model where it was, integrated at administrative level, but not seen as being integrated from a patient and caregiver perspective. So, in our experience, bringing the teams together from the community, from acute care, from the pre-op team, et cetera, and our patients and caregivers, and doing that mapping process to really engage the teams and bring the teams together so that we all saw that one patient experience. Because, in many ways, we've all for many years seen parts of that experience, but not the entirety of what that patient experience is. And it changes the conversation. It really does. And we actually had the opportunity to participate in some of the mapping exercises for the various teams. So that was really interesting, and I think an opportunity for us to provide some advice or thoughts and learn from those as well. But I think the most important thing that those team exercises do early on is that it builds trust in the team. And if there's one critical element to the success of this work, it really is that trust that you need at the front line. Building the team and building that trust at the administrative level, but really more importantly at the clinical level. And the third was an interesting process for us. So we talked about measurement a lot and evaluation. We don't, in my experience, we don't often do it enough in a way that where we share it with the frontline staff and describe, what metrics we're using and how we're evaluating in a different way. So we had really refocused on, certainly your team, Walter, from the evaluation perspective, were really critical to supporting this for each of the teams, but it was making sure that we measure the patient and caregiver experience in this work, and that's always at the forefront. How we measure cost across the episode of care, and that was a pretty unique experience, I think, for many of the teams. So practically speaking, how can you do that? How do you measure the impact of the model in a different way? So, historically, we've often looked at readmissions that, as counts of the number of episodes of readmissions, but really looking at through the lens of healthcare utilization and how many days in hospital were patients experiencing on the index event, but also in that 60-day timeframe post-discharge. And we had routinely shared that information with our frontline staff, and certainly something I think that the IFMs were really successful in embedding with their team as well, as that constant feedback in terms of how we're improving on that patient experience and caregiver experience, and how, what the impact is on the healthcare system. Because I think that's really where you get the innovation from the frontline staff, is if they know what they're working towards, and they have the flexibility to be investing additional supports, for example, in the community, but knowing that that might be preventing an ED visit or readmission. I think that that really emboldens the frontline staff to do the right thing for the patient. And that's maybe where you get some of that balance between the flexibility at the front line, but also looking at where you can help to standardize some of the processes, because I know that's certainly a tension in a lot of these models that we experience. And, hearing from the health links model and OHTs, I think that will be a pretty common experience as well.
Yeah, certainly it's, and really, I think these are really important themes that have to be at the top of awareness, I think, of leadership.
Mm-hmm.
And I think of the challenges in leadership, because it's not just one or two organizations and OHTs now. There are many other organizations, and both that leadership at that, cross providers, but then within the organizations, taking it back to the front line, and then enabling the front lines to collaborate across.
Yeah.
Yeah, really, really important learnings for people to be thinking about, and for us to be thinking about. I'm glad you mentioned data, and we are going to try and do our very, very best
Yeah.
to have just as good data this time
Yeah.
around as we did that time, which is the
Yeah.
regular feedback part, right?
Absolutely. Yeah.
You know, those are some of the success pieces. I'm sure that you also had to coach and provide supports to the teams with some of the stumbling blocks that they had in their implementations. You know, what did you find that was there, you know, the more common or maybe the biggest, if not the most common stumbling block, or what did you find that you had to do across the teams to help them most?
I mean, it was expressed in different ways, but I think probably the most common theme was really going back to my, previous comment around deconstructing the system or thinking about how to redesign it. The system is structured in a way that is funded by sector, right? So if we think about home care and acute care, and to reorganize care and to redesign it, you really need a mechanism to be resources across the system or to reorganize in a way that doesn't follow or match those silos. And that was probably the biggest challenge from a practical perspective for the teams, but I think it's also the one that the teams were most ready to embrace. And I think that was really the the challenge that they wanted to take on. But it requires some really practical coaching. And I think like for us, we've really tried to take the approach of being very transparent with what had worked well, where we stumbled along the way, because we have been doing this for a number of years, where we're not to get fixated, but where there might be some opportunities to help, bring some of the partners along. So we really took the approach of being very transparent. We hosted a number of teams on site or virtually with our finance leads and clinical leads, and really let people, from the other teams ask those very practical questions around, how do you look at reorganizing a care coordination model? How do you look at funding in a different way and bring some of those acute care resources into the community to help enable the outcomes that the teams are looking at? So that's probably the most challenging. And in a lot of ways, I think the clinical care pathway is something that people can naturally gravitate towards and can put together. I think the work of reorganizing the funding models to support this was probably the most challenging, but one I think where we really encourage very open dialogue, and we'd like to frame it as the phone a friend model, where if people needed some advice or we needed to connect them in quickly to our finance leads or to our clinical leads, we really tried to do that as much as we could.
Yeah, I think I recognized, and I guess it was with your support, the involvement of the financial groups from each of the organizations very, very early on in the models.
Yes. Yeah.
And I know relationships are one thing and clinical care lines are another, but eventually you need to move resources to be really doing redesign and it means moving money. And I think those are the very difficult conversations.
Yes. Yeah.
So thanks for raising that. I want to make sure the audience has a bit of chance, and I hear and people are chatting, and I know they'll have more questions here. Let me ask one or two more here. One of the things we found in evaluating the programs was that some programs really got to scale. As an example, the cardiac program out at Trillium, I mean, I think they had like 95% of their target patients enrolled and up and running in that model within like 9 or 10 months. It was pretty astounding. But others struggled to get the enrollment numbers in and really to find the people they were looking for, to deliver the care pathways. Now, I don't know if you thought about, that's just one example of teams that struggle. We certainly saw some variation, I'd say, across the Like, what do you think differentiated though, or helped those programs to successfully get, and out in HNHB, you did a whole LIN and got quite good. I mean, certainly the largest numbers, but also quite good. So what enables those successful implementations and that kind of scale?
Well, it's a really good question. And I think if we look at the outcomes across the 6 teams, that there's no doubt that, enrolling a high volume of patients and really, like you say, getting to scale helped to demonstrate if there was or wasn't an impact for sure. In some cases it was, I think, sort of a purposeful approach by the teams, and maybe there's some important learnings here for the OHTs as we think about the year 1 and year 2 population. There, some teams, I think, in many ways, rightly, we're taking a very thoughtful approach and starting with a small cohort of patients. So if we think about, our COPD and heart failure patient population, we might have had a very a more narrow definition for those patients that they were enrolling. And by virtue of doing that, had a smaller number of patients that were enrolled. Now, the positive side of that is that you get to learn from those smaller number of patients. And I think it, in some ways can be easier to, redesign the model as you go. But it's challenging in terms of getting that momentum in terms of the model and certainly, being able to learn. I think it was Mark who said earlier, getting the data quickly enough so that if you're on the right track or not really does imply getting a large enough volume of patients so that you can see sort of meaningful impacts one way or the other. So I think that's an important consideration for our OHTs, because I think sometimes if we try to narrow the patient population too much, it can take years before we get to that point of being able to make some meaningful decisions. So I think certainly that's a consideration. I mean, if you think about COPD and heart failure, I mean, typically they would be your largest cohort of patients within the medicine program. So there should be an opportunity, or could be an opportunity to ramp up quickly. But that would be, I think that would be one of the learnings from that.
Okay, thanks. I want just to ask the audience to start, maybe if you have further questions for any of our speakers today, to use the chat. I got one more question for you, Carolyn.
Sure.
Jennifer, near the end, talked about some of the structural barriers that we face in health links that are still with us today. And one of those was around physician payment. We haven't included physician payment in our bundled care models here in Ontario, or in many of our other models. But when I look around the world and I do some comparative work in other jurisdictions, bundled care often starts with physicians, but certainly they're always involved. How much of a barrier do you think that is in Ontario? Or how do we adapt, or maybe we just need to figure it out somehow?
Well, no, I think it's a critical question. I mean, we were fortunate in our very early days of the ICC program back in 2012 that our surgical leads, our physicians, and our medicine docs were very amenable to taking those phone calls, all the time, and providing advice to the team, often without a payment or a mechanism behind to support that. So we were fortunate that they were eager to do it, but also recognized that this could be a barrier going forward, right? Certainly if you look at implementing at scale. I know some of the IFM teams, struggled with how to incentivize the follow-ups after discharge. And so I think it's a really critical piece. One of the things that's actually been quite unique about the last few months, despite all the challenges with COVID, is really the ramp up of virtual care and ways for reimbursement around that model. So that's something that we've certainly taken advantage of in our ICC program. But I agree, Walter, and I think this is coming up as a common theme in the OHTs, rightfully so. I think we have to find a way to recognize the different kind of work, enablers to support this, because it's only successful if you're able to get that advice from the entire clinical team when those patients are in the community, if you want to avoid those ED visits or readmissions.
Thank you. I'll welcome everyone to be ready on your coming off mute, the speakers today, and come back a few points in the chat and encourage people to add more questions. There were some ideas actually also coming up in the chat here. One actually from Hamilton Health Sciences around some innovations being led and thinking about even vulnerable populations impacted by social determinants of health, and some others. There were some definitely comments early on about how our research, so this one actually came into us, do you think our research is influencing current policy around the Connecting Care Act and direction of OHTs? And I would say that when we start to hear other people use our language and not quoting us or citing us, that to me is our sign of impact. I mean, certainly we don't do, we're not necessarily tracking each and every quote and attributing, but to me, when we start to see that language, and so, you know, things move subtly and people hang on to good ideas. And when they start to see examples, and I mean, I think even today, some of the examples that are coming to light from our conversation also can impact on policy in subtle and small ways. A couple of comments coming up here and thinking about Alan Katz noted physician leads and OHTs themselves, trying to figure this out exactly. And the OMA, and we've had some conversations with some of the groups within the OMA about trying to figure this out. And in fact, had a primary care practice lead send me or send our team actually a note, I think after our last webinar around why would I do this over and above other quality improvement activities that I'm already doing. So I'm gonna actually just put it to all people now, like specifically around this idea of engaging in OHTs. Are you having any difficulty getting people to buy in? So I'm gonna go back to Jennifer first and then to Mark, and then I'll come back to Carolyn. Because I know you're all very involved in different, and you have different perspectives because Jennifer's kind of, I think, a couple multiple Marks in the East and Carolyn in Hamilton. So,
yeah. So yes, and maybe I'll just highlight one group because in a couple of our, well, 3 of them, I guess, we're just in the process of creating these CDMAs, the collaborative decision-making arrangements. And so I'm just going to highlight boards because boards are trying to figure out where their organizations fit. What does it mean for governance? And when the OHTs were launched, it was with the sort of endpoint of population health, one funding envelope. And I think that was really scary for boards. And I think in some ways it actually slowed things down a bit. I think with the new CDMAs, they feel a little better. But I think that's one group that we have to think about. What are the answers to the questions they're asking?
Yes, so maybe Walter, going from that kind of high governance level right down to the front lines, as Carolyn was talking about before, you know, I do think it is about building trust at that front line and demonstrating value at the front line for frontline providers to want to engage. And I think we spent a lot of time at that, but it's how do you take a potentially nebulous concept like OHTs and make it really viable and practical at the very local level? And I don't mean, you know, in our case, East Toronto is local. I mean, there's 21 different communities in East Toronto, and in each community, there's a whole bunch of different primary care, community support providers, you name it, different mix in that local neighborhood. How do you make it really relevant at the local neighborhood and value at the local neighborhood? That's the trust to be built and the investment of time and effort and funds to be built to really make it work. It's at both levels.
Any to add, Carolyn?
Maybe just to add, like when we think about the provider experience, you know, it is just as important to be including what that physician experience is. And I think that's been a pretty common theme when we're thinking about how do we refer patients, how do we, you know, make the process more seamless for patients. I think we also have to consider how we make it easier for providers to provide care. That was a really important win for our physician colleagues early on in the ICC model. So even though it wasn't a direct compensation for a lot of the work that they were doing, it did make their work easier, right? And so I think that's a pretty important for us to be considering across the board.
Okay, thanks. We're almost at time, but I am going to push one other element that I'm really surprised that we haven't seen in the chat, actually, which maybe speaks a little bit to some shyness. I do know that early on, when we went back to that starting poll, there were patients and caregivers listed as being participants here. And I will say that, you know, as we were putting this together, I failed and in leading putting this together and not having a very strong patient and caregiver voice today here in this webinar. You have seen patients and caregivers involved in some other webinars that we have provided. Today would have been a good example to have them, but that didn't happen. But I'm just going to ask us now to take maybe less than a minute each just to say, if there's something you learned about the role of patients and caregivers from your experience that you can parlay into OHTs now, what would that be? And I'm going to go back to Jennifer first again.
So I think it's tremendously important, and I know on both the Ontario Health Links as well as the OHTs that where we've had that strong patient voice, it has made a huge difference.
Mhm.
The complication is how to get it. And how to get a good representation, how to get ongoing representation, how to ensure involvement, how to enable involvement. So I think it's incredibly important, and I think we got some work to do in terms of how to make it work in our own context.
Anything to
Yeah,
add, Mark?
building on that, I think we were successful in the Health Links days of having patient advisors not only involved in the kind of the frontline pathway development, but also at the governance table for the Health Link.
Yeah.
And we've mirrored that again at the
Yeah.
OHT level, where we have very strong advisors for us right at our CEO table governing the OHT, in addition to involved in the many different individual pathways or populations. And then, ultimately, as we get better at building out OHTs at the really local community level, it's having folks from the community for the community involved. That'll be our next evolution that we have on our map to push to.
Thanks. And Carolyn,
Maybe just one really quick piece of advice or thought that I have is, patients and caregivers obviously can give great insight and help to design the care pathway, but I agree, don't only include them in that. They need to be part of the discussions around finance and resources and allocation, because in some ways, I think that's where we got the most valuable input in terms of how we prioritize, the finite resources that we have. So I think being at the table for all those discussions is key.
thank you all so much. I'm just going to close off now with just one last little check base on our own poll here. And I was thinking at the end of the day, what do we want to know? Well, I want to know if this was a good use of people's time. Did you learn something useful here today that will help you advance your OHT? That's our question now for the audience, just on our way out. I'm gonna leave it up just for a little bit. There the families and the patients are in the chat box now coming to life. Thank you very much. And don't feel shy to push us on these.
Mm-hmm.
We need to be pushed and we can be challenged. And I appreciate the opportunity to be challenged and pushed along the way. Okay, here's our moment of truth. We're gonna close this out. And share out, and actually it's quite good. We still have 140 something people on the line, and with full votes in, 95% thought this was a really good use of their time, and we'll do better for the next 5% next time. I really want to thank everybody for coming out, also particularly Agnes and Gaia, Carolyn and Mark and Jennifer. Very generous of you to do this with us today. And so I just want everybody to be aware that we have, everyone's involved all the way along. And we do, this is a regular series, fourth Tuesday of the month. Today we checked the box on generation of integration and lessons learned from Ontario. We have upcoming next month a focus on measures for local evaluation and how to really do this at the front line. So Carolyn highlighting that use of data, and we have very interesting examples coming up next month. In the new year, we're going to turn our heads a little bit more to some of our evaluation measures and thinking about population health management. Please stay tuned, sign up. We do load these up onto our website on the Friday following the events. Sometimes we're a day or two late, but we try and do that. And really look forward to seeing you all again next month. And please stay in touch along the way. Have a good afternoon, everyone.
Thanks. Bye.